tell a patient or a family, you only have 5 days left, you only have 2 days left. It's in God's, it's up to God, really, how much time we have left. So it's very difficult for them to try to guess how much time a patient has left, but we really do need to have some kind of timetable on it so the family knows what to expect. So, so we tried to implement this. We in-serviced our critical care physicians. We went to various committees trying to get this going, but it's been lost to follow-up. So I'm not as much in the ICUs. Liz Young, who was the third-year resident, isn't in the ICUs anymore. And so we're not quite sure where we're going with this documentation. It's still out there. There's one idea later on that we'll share with trying to get this going. The next thing that I want to talk about is role of the nurse in the family meeting. As I stated earlier, it's very difficult for nurses to get to the family meetings, but our voice is very important. First of all, in assessing where the family is, in understanding what's going on. Usually, we get a sense very quick. A doctor comes in, explains what's happening, gives a poor prognosis picture. They walk out, and then the family is in denial right away. Of course they're in denial, and they really aren't able to process it. So re-educating the physician, coming back and stating exactly what they just stated, maybe in different words, getting that assessment and working with our physicians to continue to educate the family on really what the true realistic prognosis is. The goals of care documentation, using that form, that's the second part. Being a part of that form, helping the physician solicit all that information. And then the third thing I want to talk about is moral distress of nursing. This is a real term, and it really happens, and this is what it is. We, the nurses, may see that a patient is at the end of their life. However, the family might not see that. They're still hoping for a cure. The physicians are talking with the family, but the family still wants to do everything. So we are aggressively continuing to treat a patient who is dying. And the doing of that treatment is falling on the nurse's shoulders. We are poking them. We are turning them. We are wiping their butt. We are doing everything that causes them pain, discomfort. It's not very dignified. And so we see and we feel the suffering of the patient. The physician isn't doing the doing. They're doing the ordering. They're talking with the family. The family, a lot of times we excuse the family from seeing a lot of that. So, can you excuse us while we clean up your loved one? And we have them wait out in the waiting room area. So, to the family, they may just be laying there looking very comfortable, but we know otherwise. And what are we going to do with this emotion? What are we going to do with what we're feeling? We need to tell the physician, and we need to educate the family. So how do we tell our physician colleagues? Just like that. You know what? I've been taking care of this patient for the last couple weeks. The bed sores are getting worse. Every time I give her an insulin injection, she jumps off the bed. It's getting really difficult to take care of her. Her suffering is more than it was a couple weeks ago. Just like that. How do we tell the family? Gently, if you have a rapport with that family, you're the one. You're the one that needs to educate them. Gently ask them, would you like me to help clean them up today? Here, you can have the washcloths. Go ahead, you can do the hands. We're going to turn her now. Most of our families haven't seen the bed sore that their loved one has. They know it's there, but they haven't seen it. So this is controversial. A lot of nurses aren't going to be comfortable doing this. One of our cases that we had in the ICU, this was instrumental in getting the family to understand that really the end of the road was here and we needed to withdraw support. It was an 88-year-old trauma patient who had gotten in a car wreck, multiple bones broken, lung contusions, was in C-spine precautions for weeks. She seemed to rally the first week. Thought, well, maybe, but an 88-year-old trauma patient usually doesn't, the chances of her surviving are very slim. She slowly went downhill week after week, got trached, got pegged. went into renal failure, was on dialysis, was on continuous pressors. We couldn't wean her from the vent, and yet the two sons continued to want to keep her alive. We wanted palliative care to come in and help sort out the issues. They actually did, but this was after she had already had 4 rotations of attendings, and it was hard to sort out. The family just wasn't quite sure where to go with it, the two sons. Finally, we had one more family meeting. A nurse that became very close to them invited them in to help clean her. Verbalized, you know what? I've continued to see her suffering day after day. Did you know that when I put my stethoscope on her chest, she jumps off the bed? She had had an old mastectomy, and the pain there was still very palpable. She fought us every time we touched her. The family really didn't realize that until we told them. And that was the turning point that helped the family really let go of her, and we ended up withdrawing support. And she died in the unit. So these are the things I bring up for the role of the nurse in the family meeting. Okay, we're gonna, oh, wait a minute. There were 2 other things in the ICU. So we've gone over the memory kits. Burn unit comfort care order set, this is in the works. So our ICUs have a separate comfort care order set where we are going to withdraw support in the ICUs, and they're not gonna go down to the floor. The burn unit has started to create it. It's not been implemented yet, and that's because the state has told them as a burn unit you need to have an ICU comfort care order set. It has not been brought to the other ICUs yet. Also, I want to talk about transition from ICU to the floor as a comfort care patient, the role of the resource nurse or the ADT. We were having